start the session. So in this session, we are going to discuss the old 5 years NEET PG question papers, only psychiatric questions. We are going to discuss the questions as well as the relevant concepts. Okay. So psychiatric the last 5 years, they have asked minimum 2 questions to maximum 7 questions from psychiatry. So maximum you can score from 8 marks to 28 marks. So even though the score is less, you can score it very easily. You need not remember any criteria, any guidelines, or any dose ranges, or any complicated things and all. So you need to know some diagnosis and treatment. That's all. So this 28 marks, you can take it very easily. And when you revise the last 5 years, you can take minimum 20 in psychiatry, right? So we are going to concentrate on the repeated topics and important concepts only in this session. So just we are rush through the concepts, and I am trying to help you to revise, right? So coming to the first question, a patient comes with complaints of difficulty falling asleep. He consumes black coffee 1 hour before bed. Which of the following is the role of caffeine in wakefulness? So they are asking about the role of caffeine in wakefulness. So whenever you come across a question, you read the question carefully, read all the options carefully, then think about what concept they are asking. Then you try to choose the correct answer, right? So first option they have is caffeine has no effect and he can continue taking black coffee. B, caffeine causes release of chemicals from locus coeruleus that causes awakening. C is caffeine has histaminic action in brain that leads to awakening. Caffeine inhibits adenosine receptors, thus leading to awakening. So what they're talking about is they're talking about sleep and neurotransmitters involved in sleep. So this is the concept we need to know, right? So there are 2 states we know. One is wakeful state, another one is sleep state. So when you have wakeful and sleep state, so there are few neurotransmitters help you to be awake. So these are the neurotransmitters. Most of them are stimulatory neurotransmitters. Stimulatory will stimulate you and it will keep you awake. So what are those? Serotonin, norepinephrine, histamine, and glutamate. One more hormone which makes you to awake, that is orexin or hypocretin. So these are the hormones useful in wakefulness. Which neurotransmitters are making you sleep? These are called as inhibitory neurotransmitters. So they will inhibit your CNS. GABA, galanin, adenosine, and one more hormone, that is melatonin, which makes you sleep. So it's a simple calculation now. When you increase these neurotransmitters, the neurotransmitters increase or idoda agonist nama kudukumbodo, we will be awake. When these neurotransmitters are blocked, we will be sleeping. Likewise, when the neurotransmitters increase pannumbodhu, it will help to sleep. Either namma inhibit pannumbodhu, the person will be awake. That's all. Simple, right? So what happens to caffeine? So when you take coffee, which contains caffeine will inhibit adenosine. Adenosine inhibit panna ennago, the sleep state will be inhibited and the patient will wake up. So this is the mechanism of action of caffeine. So what is the answer for this question? So the answer is caffeine inhibits adenosine receptors. Caffeine inhibits adenosine receptor, thus leading to awakening. So this is the answer. So nama vandu idoda சேர்த்து இன்னும் கொஞ்சம் additional questions பார்க்கலாம். Another one neurotransmitter is called as acetylcholine, which is a special neurotransmitter which involves in wakeful state as well as sleep. So adenosine vandu nama awake help பண்ணும் and it will help for REM sleep also. So this is a one special neurotransmitter you have to remember. And in the question you have one action, right? Locus coeruleus. So which is the chemical released from locus coeruleus? That is acetylcholine. And serotonin is released from racing nucleus. So coming back, caffeine has no effect? No, this is wrong. Caffeine causes release of chemical from locus coeruleus? No. Caffeine acts on adenosine, not on acetylcholine. Caffeine has histaminic action in the brain? No. So this is the answer. So, questions when you add antihistaminics, what will happen? So you are antihistaminic this will block the action of histamine. So the awake state will be blocked. So it will lead to sleepiness. அதனாலதான் antihistaminic drugs are promoting sleep. Sedation is the side effect. Okay, so அதே மாதிரி when you give lemborexant is the one of the latest drug we have. So lemborexant enna, the name itself is saying it is orexin antagonist. So when you block orexin, what happens? Wakefulness will be blocked and the patient will sleep. So these are the sedatives we can use. Agomelatine is the melatonin agonist. So what happens when you give melatonin? Patient will sleep. So these are the three main drugs which can cause sedation, which can be used as hypnotics, right? So these are the possible MCQs related to this question. Coming to the second question, which of the following SNRI is used in treatment of ADHD? So the options are guanfacine, methylphenidate, reboxetine, modafinil. So for this, you need to know about the treatment of ADHD. Treatment of ADHD, we use two types of drugs. One is stimulator, another one is non-stimulants. So stimulants la rendu drug irukku. One is methylphenidate, another one is amphetamine. Rendume enna pannuna, it will inhibit the reuptake of dopamine and noradrenaline. This is the mechanism of action of stimulants. Okay, so what is the side effect of these stimulants? It is contraindicated in seizure disorder. What happens is it will stimulate CNS, so it will cause seizure. So you should not give these drugs in seizure disorder. Another one class is non-stimulants. The non-stimulants, we have three drugs: atomoxetine, clonidine, and guanfacine. Atomoxetine is SNRI. Other two are alpha-2 agonistic drugs, which inhibits adrenergic release. So what happens? Adrenaline coming up, the side effects will be hypotension and bradycardia. So treatment of ADHD, you need to know 5 drug irukku: methylphenidate, amphetamine, stimulants, atomoxetine, clonidine, guanfacine, non-stimulants. You need to know the mechanism of action and important side effects. That's all. So coming back to the question, all these drugs are used in ADHD, but which is the SNRI? Actually, the answer is atomoxetine. But here atomoxetine is not there, so we can choose reboxetine, which is the same class of drug which can be used in ADHD. You can easily remember venlafaxine and duloxetine. So duloxetine, atomoxetine, reboxetine, or SNRIs. So coming to the third question. A 45-year-old woman presents with feeling of nervousness, abdominal pain, and diarrhea. She has history of heartburn and indigestion for 25 years. She gives similar complaints in the family of being tense and nervous. What else symptom do we expect to see in this condition? So they are giving some symptoms, and they're asking what is the diagnosis, or what else you can expect in this condition. So whenever you come across a case in psychiatry, just remember this, whether this case belongs to psychosis or neurosis. Which spectrum is this belong to? Among psychosis, we have only two, either schizophrenia or mania. In neurosis, we have depression and anxiety. That's all. Okay, so here they have already given feeling of nervousness, abdominal pain, diarrhea, heartburn, indigestion, being tense and nervous. So where this belongs to? Neurotic. Definitely this is not depression, because there is no other depressive symptoms are given here. So the patient is anxious. So what are the other symptoms you can expect in anxiety? Tingling of extremities, because neologism is a psychotic symptom. You can see in schizophrenia, idea of reference, hallucination, all are psychotic symptoms. This only one thing is neurotic symptom, which can be seen in this condition. So fourth question, an alcoholic patient presented to emergency in an unconscious state. Relatives state that he had an episode of binge drinking 1 week back. Examination, his glucose was 49. What is the appropriate management? So ADS is one of the high yielding topics in psychiatry. So what do you want to know is the withdrawal symptoms and the treatment of withdrawal, that you need to know. Okay, so alcohol withdrawal, we have two types of withdrawal. One is simple withdrawal, another one is complicated withdrawal. Okay, already the hint will be given in the question. Patient is alcoholic, chronic alcoholic, binge drinking will be there, and the marla kudichitaangnale you can take it as the patient is having alcohol withdrawal, presenting to you with alcohol withdrawal only. Okay, so in simple withdrawal, patient will have palpitation, tremors, sweating, insomnia, and anxiety. Okay, this role will be there. Complicated withdrawal, patient might present with seizures, hallucinosis, or delirium tremens. Seizure will be GPCS or status epilepticus. Okay, mainly patient will present with GPCS. Hallucinosis, patient will have auditory hallucination in clear sensorium. This is very, very important. Auditory hallucination in clear sensorium is hallucinosis. In delirium tremens, patient will be in delirium. So altered sensorium will be there. Here also will have hallucination. So here, instead of auditory hallucination, patient will have visual and tactile hallucination. Apart from that, there will be disorientation, clouding of consciousness, agitation, delusion, illusion, and sleep-wake cycle reversal. Everything will be there. So remember these two things. This is very important. Auditory hallucination, clear sensorium is withdrawal hallucinosis. Visual hallucination or tactile hallucination in altered sensorium in an agitated patient is delirium tremens. Okay, here. So mostly you will be given the complicated withdrawal state only, not simple withdrawal. Right. So this is the symptomatology. So what is the treatment? IV thiamine and benzodiazepines. Why we are giving thiamine? To prevent Wernicke's encephalopathy. So IV thiamine is the treatment of choice to prevent Wernicke's encephalopathy and for the treatment of Wernicke's encephalopathy. Okay. So this you should not remember. It's very, very important. Benzodiazepines are given to reduce the withdrawal symptoms, to reduce the withdrawal, mainly the palpitation, tremors and all will be reduced by benzodiazepines, right? Okay. So coming to Wernicke's encephalopathy. So Wernicke's encephalopathy will present with GOA, G-O-A. G is global confusion, O is ophthalmoplegia, and A is ataxia. So GOA is the triad in Wernicke's encephalopathy. Mainly in ophthalmoplegia, 6th cranial nerve is involved. Okay, that you need to remember. Another one is Korsakoff's psychosis. Here, the patient will present with memory disturbance and confabulation. Memory deficit will be there and confabulation will be there. What is the difference between these two? Wernicke's is an reversible condition. Korsakoff is an irreversible condition. That's all. So, this is enough regarding alcohol withdrawal. So, coming back to the question. Alcoholic patient presented to emergency in unconscious state. So, he is an ADS patient. Comes to you in a hypoglycemic state. What is the appropriate management? So any patient comes to you in alcohol withdrawal, first step you have to give is IV thiamine. Followed by, so the patient is having hypoglycemia, so followed by you have to give dextrose infusion. So this is the correct answer. So what will happen when you give dextrose first? So because of thiamine is not there, your dextrose cannot be metabolized without thiamine. So each and every ADS patient will have thiamine deficiency. So you have to first replenish thiamine deficits, then only you can give dextrose infusion. Right. Next question. Which of the following drug is used in opioid substitution therapy? So in opioid substitution, only 2 drugs are used. So opioid substitution therapy, only 2 drugs are used. One is methadone, another one is buprenorphine. Okay, methadone, another one is buprenorphine. Okay, don't confuse buprenorphine with bupropion or something else. It is called as BPA, buprenorphine. Okay, so either the choice should include buprenorphine or methadone. That's all. So it's a direct question. So next question, 32-year-old male needs to be dressed in a female lingerie and high heels to feel aroused and have intercourse with a female. He denies any sexual arousal, attraction towards males. What is the likely diagnosis? See, he is a male, but he is dressing like a female. He is a male. He is attracted towards female, but he is not attracting towards males. So definitely he is not a homosexual. Okay, so he is heterosexual. Right. So this homosexual orientation is gone. This is not the answer. So he is testicular feminization. There is nothing suggestive of testicular feminization. There is no hormonal details have been given here. So this is not there. Gender dysphoria. There is no clue that this male is identifying himself as a female. So there is nothing like that. So he is identifying himself as a male only, but he is dressing like a female. So gender dysphoria is gone. Okay, so what is this condition? Male dressing like a female is called as transvestism. Okay, male dressing like a female or female dressing like a male is called as transvestism. Why he is transvestic? To feel aroused for sexual arousal. So for this sexual arousal is called as fetishism. So this is called as transvestic fetishism. Okay, why not? This is homosexual orientation. He is attracted towards males, not towards female. Females, not towards males. So this is not homosexual. He is identifying himself as male only, not female. Suppose this male is identifying himself as a female, so this will go into gender dysphoria. So this answer for this question is transvestic fetishism. Coming to the next question, 19-year-old girl came agitated to the emergency department after consuming some drug. With previous history of suicidal tendencies, parents do not know the mode or route of administration. She presented with tachycardia, tachypnea, diaphoresis, and dilated pupils. What is the likely drug administered? What they have given is cocaine, chlorpheniramine, morphine, and heroin. So cocaine is a sympathomimetic drug. Chlorpheniramine is an histaminic drug. Sorry, antihistaminic drug. Morphine and heroin are opioids. So you need to know the mechanism of action of all this. So coming to opioid overdose, patient will have sacrum. SACRUM. S is sedation, A is analgesia, C is constipation, R is rigidity, U is urinary urgency, and M is meiosis or pinpoint pupil. Pinpoint pupil. Okay. So sympathetic drugs are cocaine, methamphetamine, MDMA, and amphetamine. So what happens? It will increase the sympathetic surge. So what happens? It will increase the heart rate, BP, tachypnea will be there, diaphoresis, and it will dilate the pupil. So that is called this is pinpoint. This is dilated pupil. This is mydriasis because it is having sympathetic action. So what happens when you give antihistaminic? Patient will be sedated. Okay, we have already discussed this. Patient will be having sedation. Okay, so here the patient is having tachycardia, tachypnea, diaphoresis, dilated pupil is the clue here. Which will cause dilated pupil among these? So this is sympathetic drug poisoning. And among this, anything can be in the option. Here they have given cocaine, so cocaine is the answer here. Right. Next question. A girl was referred to psychiatry OPD by plastic surgeon. She had visited multiple plastic surgery departments requesting full facial reconstruction. She complains of dark blemishes and spots in her face which are not actually present. She always says that she's ugly and looks constantly in the mirror and at the back of the spoon and windows. Her mother assured her of no such issues. Still, she persists on getting the surgery. What should the psychiatrist do? There are some options. Okay. So now tell me, what is this condition? So this condition is called as body dysmorphic disorder. Okay. So this patient is having preoccupation about the deformity in her body. So she is feeling that her face is not correct, right? So she has some dark blemishes in her face. So preoccupation about the deformity will be there. Okay. So they will go for a repeated doctor shopping will be there. Doctor shopping. She is going to multiple plastic surgeons and she is asking for repeated procedures. She's asking for surgeries repeatedly and she is constantly looking at the mirror. So this is called as checking behavior. So checking behavior will be there. Okay. So this will come under OCRD, obsessive compulsive related disorder. So this is called as body dysmorphic disorder. Patient has preoccupation about some deformity in her body, repeated doctor shopping and repeatedly asking for the procedures will be there, and there will be constant checking. Patient will not be assured by repeated reassurances. So what is the treatment of choice for BDD? Treatment of choice is SSRI and CBT. Okay. So what is given here? Start her on SSRI. This is the answer. Give fitness for surgery? No, not at all, because she has no deformities. Start on atypical antipsychotics? No. If she has delusion, we could have added atypical antipsychotics, but this is not a delusion, this is BPD. Insight-oriented psychotherapy is not possible in this condition. So first you have to start her on SSRI, then you can start CBT. Third question. A girl presented with multiple episodes of loss of consciousness. Multiple episodes of loss of consciousness. The episodes usually happen in the presence of family members in the morning. She regains consciousness after 15 to 30 minutes. Usually remembers even during the episode. There is no history of tongue bite or incontinence. This is very, very important. What should be done in this scenario? Okay. So you have to first come to the diagnosis, then go to the options. Okay. So there are only 2 DDs for this condition. She has multiple episodes of loss of consciousness, which is resembling seizures. Right. But there is no history of tongue bite or incontinence, which is essential for seizures, but that is not there. And these episodes are usually happening in the presence of family members in the morning, and she is remembering the events. So this is called as pseudo seizures. Okay. So we need to know how to differentiate pseudo seizure from seizure. So in true seizures, there will be loss of consciousness, limb movements will be there, uploading of eyeball will be there, tongue bite and incontinence will be there. These will be absent in pseudo seizures. And injuries are more common in true seizure. In pseudo seizures, injuries will not be there. Okay. And true seizure can occur in the night also. It can occur when the patient is alone. But pseudo seizure will not occur during sleep, because these are not produced by your brain. This is a psychological seizure. So it will not happen during night. It will happen when everyone is around. It will not happen when the patient is alone, right? It's kind of attention seeking only. So it will not happen when the patient is solo. And when you examine the patient, plantar will be extensor during true seizure, and in pseudo seizure, plantar will be flexor. Okay, so this is happening due to, and another one is EEG will be abnormal in EEG will be abnormal. Abnormal in pseudo seizure. However, in true seizure, EEG will be normal. Why? Because here EEG will be normal. Why? Because here this true seizure is due to the non-synchronous waves in the brain. Pseudo seizures are due to some psychological distress. Psychological distress, not due to the brain dysfunction. So the answer for this question is pseudo seizure. So what will you do for pseudo seizures? Main thing is therapy. CBT is the drug of choice. Sorry, treatment of choice. Here they have given behavioral therapy, ketogenic diet, valproate, initiate abortion therapy. No, CBT, behavioral therapy is the drug of is the treatment of choice. Ketogenic diet not advised. Valproate can be given when it is true seizure, but it is not a seizure. Okay, so you should not give valproate. Initiate abortion therapy. Abortion therapy is given for alcoholic patients. Okay, not in pseudo seizures. Next question. If a child with ADHD goes untreated into adolescence, what is he most likely to develop? Okay, so the child who is having ADHD can develop oppositional defiant disorder, can develop conduct disorder, can develop antisocial personality disorder. Okay, so this is called as externalizing spectrum disorders. So in ADHD, the patient will have inattention, so you know, right? Attention deficit hyperactivity disorder. So the patient will be having attention deficit, hyperactivity, as well as impulsivity. Oppositional defiant disorder, patient will not obey any, the child will not obey any authoritative figures. They will be opposing them. In conduct disorder, along with not obeying authoritative figures, the child will involve in stealing, lying, truancy, animal cruelty, and fire setting behavior will be there. So this is conduct disorder. In antisocial PD, so when the child grow up, the patient, so when the child is around 5-6 years old, it will be ADHD. When he is 10-12 years old, he will be ODD. When he reaches 15-16 years, it will develop conduct disorder. When the child ages more than 18, it will develop antisocial personality disorder. So this will evolve in a spectrum. That's why we need to intervene ADHD earlier. So in antisocial PD, patient will involve in crimes, substance use, and aggression. So what is the answer here? Patient will develop conduct disorder. Okay. Next question. 19-year-old presented to psychiatry OPD. He has a charming persona, well composed and behaved in front of interviewers. His mother complained of him getting into fights, bunking classes, drinking alcohol, getting involved into police cases. So he is doing crime, is involved in substance use disorders. So what is his personality? This is antisocial personality. Right. So even they have charming persona, behave in front of others, they will be manipulating. Okay, most of the antisocial people are manipulative. Okay, so they might look good, but their actions will be so criminal. So these are the 3 clusters of personality you need to know. Cluster A, cluster B, and cluster C. Cluster A is a suspicious personality. They will not believe anybody. So they will be very suspicious. So under cluster A, we have paranoid, schizoid, and schizotypal personalities. Cluster B will be very emotional persons. So here we have antisocial, narcissistic, histrionic, and borderline personality. Okay, antisocial we know already. Narcissistic will have self-love. I am the big person in the world. I am superior to others. You have to listen to me, kind of guys. Histrionic guys are like cinema actors, kind of person who will be attention seeking and very self-loving personalities. Borderline personality, otherwise called as emotionally unstable personalities. They will be having emotional and instability and substance use disorders, repeated self-harm behaviors, fear of abandonment. Okay, like very frequent mood swings. These are the hallmarks of borderline personality disorders. Cluster C is very anxious personalities. Either they will be having anxious avoidant personality, OCPD or unencastic or dependent personalities. These people will be very anxious to make friends, avoidant towards people. They will be like what we say introvert. Okay, introvert, the word introvert refers to anxious avoidant personalities. OCPDs are very strict, perfectionist, very clean and composed people. So these are called as OCPD. Dependent personality or dependent on others. So this thing you need to know. Main is I need to know antisocial and borderline and OCPD. Borderline have fear of abandonment, frequent mood swings, repeated self-harm behaviors, and substance use. Right? So coming to the next question, a patient was brought to the hospital after a road traffic accident. Which of the following drugs would be best to avoid the withdrawal symptoms? So when you talk about withdrawal, alcohol withdrawal, we have only 2 drugs. One is thiamine, another one is benzodiazepine. So here what they are asking is, what is the best drug to avoid withdrawal symptoms? So thiamine is to avoid venous encephalopathy, benzodiazepine is to avoid withdrawal symptoms. So what is the drug of choice here? Any benzodiazepine. So which is the benzodiazepine here? Lorazepam. Okay. So coming to the next question. A schizophrenic patient was prescribed a drug A after he did not respond to haloperidol and thyroidazine. He now presents with excessive salivation increased blood glucose and hyperlipidemia. What is drug A? The only one drug which can cause excessive salivation in psychiatry is the only one and only clozapine. Okay, so this talks about side effects of antipsychotics. This you need to know. So, coming to side effects of antipsychotics, there are mainly two side effects. For first generation antipsychotics, EPS is more common. Second generation antipsychotics, metabolic syndrome is more common. Among these SGAs, metabolic syndrome is more common with clozapine and olanzapine. Okay. Among SGAs, EPS is more common with risperidone and amisulpride. Okay. And the drugs which causes QT prolongation is thioridazine, timoside, Q-tipin, clozapine, and also amisulpride. And amisulpride is more prone to cause hyperprolactinemia also. So this list you need to know. For example, in this case, if excessive salivation is not there, they're asking one drug which causes increased blood glucose and hyperlipidemia. Still, the answer would be clozapine. If clozapine is not given, patient is developing increased blood glucose and hyperlipidemia, clozapine is not there, then olanzapine will be the answer. Olanzapine should be in the option, right? But the only one drug which causes excessive salivation as well as constipation is excessive salivation and constipation will be caused by clozapine. Okay, done. So just brush up your dopamine pathways also. We have 4 pathways. Mesolimbic, which is responsible for positive symptoms. Mesocortical, responsible for negative symptoms. Tuberoinfundibular, which increases prolactin. Nigrostriatal, which is causing the Parkinsonian symptoms or EPS, extrapyramidal symptoms. Right. So your first generation antipsychotics will act on all 4 pathways. Your second generation will act only on mesolimbic and mesocortical pathways. Some light over in extrapyramidal symptoms also. We have 4 types of extrapyramidal symptoms: acute dystonia, akathisia, drug-induced Parkinson's, and tardive dyskinesia. Acute dystonia is a very acute condition which will occur in minutes to hours, which will present with muscle spasm. Example is torticollis. Treatment of choices antihistaminic. Example, Phenergan. Akathisia is defined as subjective and objective restlessness, which happens within hours to weeks of antipsychotic starting. Treatment of choices, beta blocker, usually propranolol, non-selective beta blocker, or anticholinergic like PHP. Drug-induced Parkinson presents with rigidity, resting tremors, and bradykinesia. It will occur from days to weeks. Treatment of choices, anticholinergic, mainly PHP. Okay, so for first 3 conditions, the first and foremost step is reduce or stop offending agent, offending antipsychotic if possible. Otherwise, you can add the secondary agents to reduce the symptoms of EPS. Another entity is called as tardive dyskinesia. Tardive is late, so it will develop very lately. It might take months or years to appear. It appears as orofacial chewing movements due to dopamine hypersensitivity. Okay, here the treatment is different. Here we are giving anticholinergic agents, but here you have to stop anticholinergic if it is given. You can add antioxidants like vitamin E, and BMAT inhibitors can be added, like tetrabenazine and valbenazine can be added. So this is tardive dyskinesia. This will take months to years to develop. Okay, so because it is tardive, so this you need to know. So treatment of choice for acute dystonia is antihistaminic, akathisia, propranolol and THP, Parkinsonism is THP, tardive dyskinesia, benazines. Okay. Next question: woman who is 4 days postpartum. 4 days postpartum present with carefulness, mood swings, occasional insomnia. What is the likely diagnosis? The options are everything is postpartum, that you know. Depression, blue, psychosis, anxiety. So how will you differentiate these? So for that, you need to know the criteria for depression. So to call it as depression, the patient should have low mood, low interest, and low energy. Okay, for at least 2 weeks. So if the patient, if it is postpartum, that is called as depression. Okay, so when it is postpartum onset, patient is having all three symptoms, it is called as postpartum depression. Okay, and when the patient is having delusion or hallucination, it is called as postpartum psychosis because these are psychotic symptoms. Clear? When these two are not there and patient is having very mild depressive symptoms without any functional decline, that is called as postpartum blues. That's all. Mild depressive symptoms mean on and off low mood might be there, occasional crying spell might be there, low appetite, low sleep, less sleep might be there occasionally. Okay, but they are able to take care of the child. Their functionality will not be declined. Here in postpartum depression, postpartum psychosis, they will not be able to take care of the child and there will be functional decline. Here the function will be intact. Okay, so these are the things. So here the patient is having tearfulness, mood swings, and insomnia. There is nothing suggestive of depression. There is no psychotic symptoms at all. Patient is not at all anxious. So it is called as postpartum blues, and it is only 4 days postpartum. So it is a very mild onset of depressive symptoms which can occur immediately after postpartum for very short duration, and it is very transient. It can subside on its own. That question. 25-year-old female reported symptoms of anxiety, palpitations, sweating, breathlessness, chest pain, feeling of impending doom. She recalls having experienced 5 to 6 similar episodes in the past 6 months. Each episode lasting for 20 to 30 minutes. What is the likely diagnosis? So whenever you see a case, what you should do? Psychotic case or neurotic case? Psychosis, schizophrenia, or mania? Neurotic, depression, or anxiety? Here, what is the case? Patient is having anxiety. So they have already given anxiety, palpitation, sweating, breathlessness, the neurotic symptom. Among neuroses, the patient is having anxiety. Okay. So what anxiety? So coming to the options, everything is anxiety disorder. So it is not depression. Everything is anxiety disorder only. Which anxiety disorder this patient is having? So among anxiety disorders, take this as a baseline. Okay. When the patient is always anxious, okay, and there is free-floating anxiety. We will call it as free-floating anxiety. The patient is anxious for everything. This is called as GAD, Generalized Anxiety Disorder. Okay. When there is a stimulus and the patient is having anxiety symptoms for a shorter period or episodic pattern, that is called as phobia. For example, patient is seeing a dog and he is done for a few minutes and it is settling down. This is phobia. And there is a similar symptoms without any stimulus. Palpitation, sweating, tremors, suddenly hiking up and suddenly coming down. Episodic. That is called as panic disorder. In panic disorder, patient will have autonomic arousal, fear of impending doom, and anticipation will be there. So what is here? The patient is having episodes. So it is not GAD. So the patient is having episodes, either phobia or panic disorder. Is there any stressor like dog? There is no dog here. There is no snake here. So obviously the patient is having panic disorder. Patient is having what? Panic disorder. Panic disorder is the answer here. So another MCQ, what is the treatment of choice for these? For GAD, for phobia, for panic disorder, every anxiety disorder, we can give SSRI with or without benzodiazepines. Okay, these are drug of choice. Coming to the next question. A middle-aged man complains of very early ejaculation during intercourse. The patient is having premature ejaculation. Okay. What is a non-pharmacological management that can be advised to this patient? So for this case, you have to know the sexual cycle. So sexual cycle has 4 phases. First one is excitatory phase, plateau phase, orgasm, and resolution. In excitatory phase, you will have reduced libido or erectile dysfunction. In orgasmic phase, patient might have premature ejaculation. Patient might develop premature ejaculation or delayed ejaculation or anorgasmia. Okay, so what we need to focus on is erectile dysfunction and premature ejaculation. So in erectile dysfunction, the treatment of choices are pharmacological and non-pharmacological. Pharmacological, you Also no. Oral phenyl and intraurethral treatment is there. Main is PD5 inhibitors oral. Sildenafil, phenyl, alprostadil, and papaverine. Intraurethral alprostadil, which is PGE, prostaglandin E1. Right. Then non-pharmacological, we have sensate focus therapy and relaxation training to reduce the performance anxiety. In premature ejaculation, the treatment of choices either SSRIs, the paxlovid, paroxetine, or non-pharmacological treatment, start-stop technique or squeeze technique, which is introduced by Masters and Johnson. So these are the techniques we have. So what is the question here? Patient is having PE. What is the mechanism of action? What is the non-pharmacological management? Though the question is asking you about this. So where is it? What is the option given here? Squeeze technique. So this is the answer. Next question. A chronic alcoholic is brought to the emergency department with confusion, ataxia, painful eye movements. Alcoholic. Sixth cranial nerve also involved. What is the likely diagnosis? Alcoholic, patient is having OVA. Global confusion is there. Ophthalmoplegia is there. Ataxia is there. What is this condition called as? Wernicke's encephalopathy. Simple. 16-year-old girl has intense craving for food. She eats large amounts of food, which is followed by self-induced vomiting. What is the probable diagnosis? So the question is about eating disorders. The patient is binging and vomiting. What is this disorder? Either it is anorexia, bulimia, atypical depression, or binge eating disorders. Let's see this. So binge eating, patient will eat only binge, will not vomit out. Okay. In bulimia, patient will binge and vomit out. In anorexia, some other features are also be there. So what is anorexia and anorexia? Okay. Patient is avoiding food. Why the patient is avoiding food? Patient is avoiding food and vomiting out using purgatives or doing exercise to reduce the weight. Why? Because of body image distortion. So because of this, patient's BMI will be low. Why she is doing all these things? There will be body image distortion. Patient might be in 20 kgs or 25 kgs, but she feels that she is very fat. So that is body image distortion. So because of these behaviors, patient's HPA axis disruptions will be there, mainly present with amenorrhea. Okay, the only thing which will increase in anorexia is cholesterol. Okay, so this is anorexia. Patient will avoid food, vomit out. Because of this, her BMI will be low. Why she is doing all these things? Because she feels she is fat. Because of this, the complications will be HPA axis disruption and increased cholesterol. In atypical depression also, patient might have increased appetite, sugar craving, laden paralysis, hypersomnia. On top of that, the patient will have low mood. So what is here? Patient is having binging and vomiting. That's all, nothing else. So where is it? This is bulimia. So this is bulimia nervosa. This is a repeat question. Women 4 days, the same 4 days postpartum lady, the same experience mood swings and insomnia. What is this? Postpartum blues. 16-year-old female patient presented with over-familiarity, flight of ideas, elevated mood, increased sexual desire, and social hallucination. So there is a case, psychosis or neurosis, schiz or mania, depression or anxiety. What is this? Patient is psychotic, elevated mood, increased sexual desire, flight of ideas, over-familiarity, everything is there. So patient is psychotic. Either schizophrenia or mania, definitely there is elevated mood. So the patient is having mania. Yeah. So what are the features of mania? So in hypomania, patient will have elevated mood, elevated energy, and increased psychomotor activity. The duration will be 4 days or more. In mania, along with these three, patient will have reduced need for sleep, over-familiarity, overspending, hypersexuality with or without psychotic symptoms. Okay, the total duration should be 7 days at least. Mixed state, patient will have manic as well as depressive symptom. Okay, so what is the difference between hypomania and mania? The functionality will be preserved in hypomania, functionality will be gone in mania. Okay, so this is bipolar, hypomania, mania, and mixed episodes. So this is the baseline of mood. Okay. Anything above this is mania. Anything below this is depression. Just in the middle of the way, if you have something that is called as hypomania. Middle of depression is called as subsyndromal depression. Subsyndromal depression. Okay. One mania and one depression is called as bipolar. Okay. One hypomania and one subsyndromal depression. This is called as cyclothymia. Okay. And one option is there which is called as schizomania. So when the patient is having many symptoms as well as psychotic symptoms, this is called as schizomania. Okay. Comes under schizoaffective disorder. Schizomania and schizodepression. Cyclothymia is hypomania and subsyndromal depression. So mania, schizomania, hypomania, and cyclothymia. All four options we learned. Next question. 50-year-old male suddenly stopped alcohol consumption. So again, related to alcohol. Agitation, altered sensorium, paranoid delusion, hallucination. What is this? Altered sensorium and hallucination means that is delirium tremens. That's all. Which of the following is included in the form of thought disorder? So disorders of form of thought is form of thought, which is seen in schizophrenia. Derailment or loosening of association, neologism, tangentiality, and circumstantiality. These are the few formal thought disorders. So here derailment is there, that is the option. Obsession, which is seen in OCD. Thought insertion also, it's a thought phenomena which is seen in schizophrenia. Delusion also seen in schizophrenia. Okay, so these are the thought disorders. So this comes under form. These two comes under possession. This comes under content of thought disorders. Okay, so here the formal thought disorder is derailment. During the course of psychotherapy, the therapist has mixed conscious and unconscious feelings towards a patient. That is known as. So in therapy, we have two things. One is the patient having feelings towards the therapist. That is called as transference. Patient might love the therapist, or patient might hate the therapist, or patient will feel like the therapist is a fatherly figure. So this kind of emotions are very, very common during psychotherapy. So this is called as transference. Patient to therapist is transference. What happens ulta? When the therapist has some feelings towards the patient, that is called as countertransference. What is asked here? Therapist has mixed feelings towards the patient. That is countertransference. Only one time they have asked this question. So next question, voluntary admission can be done maximum up to how much time according to MHA? MHA is Mental Health Care Act 2017. So according to this Mental Health Act, you can admit the patients voluntarily or involuntarily. Okay, voluntary means patient themselves are coming and asking for admission for like depression, anxiety, insomnia, etc. Involuntary admissions are applicable for patients who doesn't have insight or having psychotic symptoms like schizophrenia, mania, like that. Yeah. So how many maximum to how many days you can keep the voluntary admission? So according to MHCA, the voluntary and involuntary. Voluntary is otherwise called as independent admission. Involuntary is otherwise called as supportive admission. So voluntary admission is given in section 86 of MCQ. So according to this, you can keep the patient for 30 days. After that, you can review the need for prolonging IP care. Then you can prolong up to 90 days. In involuntary, there are two sections in MCQ talking about involuntary admission. Section 89, section 90. According to section 89, you can keep the patient up to 30 days. Section 90 up to 90 days. Emergency treatment should be given within 72 hours according to MHCA. Okay, so what they are asking is voluntary maximum days, 90 days. 90 days. Okay. So next question is regarding lithium. Patient is on lithium for bipolar disorder, faster for some days due to religious conditions, later presented with seizure, tremors, confusion, and weakness. What investigation have to be done to diagnose the condition? So when you are Taking lithium and fasting, patient's lithium level will be higher. So patient is developing signs of toxicity, lithium toxicity. Okay, so to check the toxicity, what will you do? This is the condition. So mainly we have to check the serum lithium. That is the main diagnosis. To diagnose lithium toxicity, you have to check serum lithium. Lithium causes what? So for this, you need to know about lithium. So lithium toxicity can affect 4 organs: thyroid, CNS, CVS, and renal. In thyroid, patient might develop hypo or hypothyroid or goiter. CNS, tremors, hyperreflexia, clonus, or coma, delirium. CVS, fever changes, Epstein's anomaly in fetus. Renal, diabetes, insipidus, right? So these are the signs of lithium toxicity. And what will you do to diagnose this condition? You have to check the serum lithium levels, and if the serum lithium is less than 4 millimole per liter, you have to give the supportive treatment like giving IV fluids, stopping lithium, etc. When the serum lithium is more than 4, you have to go to hemodialysis. That's all. Okay. So if this question is asking you, in condition serum lithium is 5, what will you do? Your answer should be hemodialysis. Okay. Lithium causes what? Lithium causes T wave changes, which is equal to hypokalemic changes. MBBS student, she was choking with dyspnea, chest tightness, anxiety, impending sense of doom. All systemic conditions found normal. She went to psychiatry. What is the probable diagnosis? Straightforward question. What is this? It is an episodic anxiety symptoms. Okay, without any stressor. What is that? This is panic disorder. A patient falls down. With behavioral change and enuresis. False, behavioral change, enuresis. What is the condition? So the condition is about dementia. Okay, so we need to know about dementia. So only the treatment is the same. We are going to give cerebral stimulants like donate He is gait disturbance, U is urinary incontinence, D is dementia. Okay, when you take the CT, the patient will have dilated ventricles in MRI or CT. This is normal pressure hydrocephalus. With gyrus will be normal, only dilated ventricles will be there. In frontotemporal dementia, patient will be having frontal and temporal deficits, okay, which will be presented as apathy, personality changes, repetition. Even the patient might have mania. Lack of judgment will be there. Hyper religiosity or hypersexuality might be there. Carbohydrate craving might be there. Judgment will be impaired. Okay, because frontal lobe is gone. Temporal lobe is responsible for memory disturbances. So this patient might present with memory disturbance also. Okay. So when you take CT or MRI, this patient will have frontal and temporal atrophy. So mainly remember, this patient will be having psychotic symptoms or mood symptoms. This is very important. Patient might present with psychotic or mood symptoms along with memory deficit. This is 50D. In Parkinson dementia, they will be having 4 features: fluctuating orientation, sensitivity to neuroleptics or antipsychotics, visual hallucination, gaze palsy leads to frequent falls. Okay, here occipital lobe will be atrophied. Okay, in Alzheimer's, patient will have amnesia, apraxia, agnosia, acalculia, wayfinding difficulties. Here, temporal and parietal atrophy will be there. So, what is given here? Falls. Behavioral changes and enuresis. Okay, falls can be there in NPH or Parkinson's. Okay, but enuresis can only be there in frontotemporal dementia. This is a good trait. Okay, good. Gait disturbance leading to falls. Urinary incontinence, that is enuresis. Dementia, that is behavioral change, what they say. So this is frontotemporal dementia. Parkinson's dementia is otherwise called as dementia of Lewy body. This is the correct term actually. Dementia of Lewy body, not Parkinson. Okay. Next question. A patient with depressive symptoms for 6 months associated with auditory hallucination for 2 weeks. What is the probable diagnosis? Okay. So when there is a case, you have to divide either it's a psychosis or neurosis. Psychosis, we have schizophrenia. Neurosis, we have depression and anxiety. Here they have directly given the patient is having depressive symptoms for 6 months. Depressive symptoms for 6 months is depression only. But the patient is having auditory hallucination, psychosis also. So where do you put it there? Psychotic depression, schizoaffective disorder, mania depressive illness, or schizophrenia? Definitely this is not schizophrenia because the patient is having depressive symptoms also. So in some depression, the patient will have, when the depression worsens, the patient will develop psychotic symptoms also. This condition is called as severe depression, psychotic symptoms, otherwise called as psychotic depression. Okay. Schizoaffective disorder is first the patient will have schizophrenic symptoms, then the affective symptoms. Here the patient is developing affective symptoms, then schizophrenic symptoms. Okay. So the primary disorder is mood here. Mood followed by psychosis. So this is depression only. Schizoaffective patient will develop schizophrenia. Many depressive illness is other name for BPAD only. This is not BPAD. The patient is having depression, not bipolar. No schizophrenia. Okay. So last question. Identify the sleep wave marked in EEG during sleep-wake cycle. So these waves you need to know. Just brush up your physiology. So when you take EEG during sleep, you will be seeing 4 types of waves. Remember these numbers: 1, 4, 8, and 13. 1 to 4 hertz, 4 to 8 hertz, 8 to 13 hertz, more than 13 hertz. More than 13 is beta, 8 to 13 is alpha, 4 to 8 is beta, 1 to 4 is delta. So first, when you are awake, alert, listening to class or studying something, you will be having beta waves. Then you close your book and go to sleep. Just you are relaxed and lying down on your bed. Awake, not alert. You will be having alpha waves. When you slowly start sleeping, you will be having theta waves. In deep sleep, you will have delta waves. Delta is for D, D for D. Okay. So beta can be seen when you are alert as well as when you are having a REM sleep. Alpha in N1, theta in N2 stage, delta in N3 stage. Okay. So this will be the waveforms. This is the delta, very slow and low frequency waves. Okay, here the frequency will be very higher, here little more higher, beta will be very higher. Okay, so tell me what is this wave? So this is very slow wave. This is 1 second. So one wave only is there. So this is delta. Here in 1 second, 4 or 5 waves are there. What is this? Theta. More than 4 is theta. So here 10, 12 waves are there. This is alpha. What is this wave? This is very haphazard. So beta. Very haphazard, very high frequency waves. So beta waves are seen in which cycle? Either wakefulness or REM sleep. So answer is REM. Okay, this is seen in REM. This is seen in stage 1. This is stage 2. This is stage 3. Okay. So some other facts about sleep. So in REM and non-REM. So main thing you need to focus is all systems becomes regular and slow in non-REM. Regular and slow. But in REM sleep, everything is irregular. Your heart rate, your breathing, everything will become irregular. Muscle tone will be low in non-REM. In REM, you will be having A-tone, complete absence of muscle tone. Okay. Dreams will be non-rememberable in non-REM. In REM, dreams will be rememberable. Okay, dreams will be rememberable. Okay, then coming to the disorders in sleep. In non-REM, remember this only. In REM, you will have nightmares. you will have nightmares, sleep paralysis because of atonia. You might have sleep paralysis, REM behavioral disorder. That's all. Okay. These three is very, very important. All the systems will be irregular. Muscle is atonic. Rememberable dreams, nightmares will be seen in REM sleep. Okay. REM latency will be very low in narcolepsy and depression, will be increased in dementia. Remember, increase in age, REM latency will be increased. Okay. So these are the other possible MCQs you can get from sleep. So these are the waves. So here we have, what is this? This is REM sleep, beta waves. This is delta wave, which is very low amplitude waves, 1 to 4. And this is theta waves. And this is alpha wave. And this is beta wave. Okay. So another one what you need to know is sleep spindle and K complex. It's just seen in non-REM 2. Okay, non-REM, other REM N2 stage. Okay, you can see this in N2 stage. N2, you can see two things: sleep spindles and K complex. K complex will be like this. Okay, sleep spindles will be like this. Okay, regular waves. Right. That's all regarding sleep. So in sleep, you need to know the waves. Okay, frequencies, in which stage of sleep you will be getting all these things. Difference between non-REM and REM, and the disorders during in non-REM and REM. And you will be able to identify the waves as well as sleep spindles and K complex, which will be seen in N2 stage of sleep. Okay, that's all for the day.